Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello and welcome, listeners. This is Kevin MacPherson, and we are continuing our interviews of different presenters from the 2019 AAOMPT Conference. In this case, we have Alex Bengtsson. Alex is a current fellow in training with Duke University's program. Prior to that, he underwent his entry-level training through the University of Miami in Miami, Florida, and also is a certified strength and conditioning specialist through the National Strength and Conditioning Association. He's a board certified clinical specialist in orthopedic physical therapy through ABPTS. And finally, more near to what I do on a daily basis, he is an APTA credentialed clinical instructor. Now, the subject for Alex's breakout session during the conference is contributions to the advancement of physical therapy practice by full-time clinicians, with an emphasis on case studies. So without further ado, let's move into the interview. So Alex, if you don't mind, give us a little bit of background as to what the talk was about, and then also where did it come from? Why was it important to bring this information?
Right. Yeah, so the general idea essentially is, kind of describing why case studies are important in the first place, what place they have in the literature. The original idea kind of came from conversations I had with full-time clinicians who said they just didn't have the time to do case studies, or another big one I heard was, I don't even know where to start with a case report, because most clinicians that you'll ever talk to, if not all of them, will say they had some interesting case study at some point or some interesting patient that would have been helpful for other people to know about or to share. So that's the original idea behind that. And I've also spent a little bit of time in some environments where the value was not quite recognized. So I think that's kind of where the idea came from, and just trying to share that and share some of the strategies to get going.
Good. Now you had really, if I recall, 4 kind of criteria for these would be good cases, like good types of cases. One of which was that unique case. Another one was a case with value. The other 2 were...
So differential diagnosis, medical screening, those kinds of things. And with the value is more unprecedented value. And the example I gave in the lecture was one of my former students, Zach Carroll. He did a 5x5 presentation on a tactical athlete who had a synovial hemangioma, which is normally treated just by surgery or a wait-and-see approach. But in the literature, PT has not been described as a form of treatment. And he was very successful with the treatment. And I think that's another good case idea, because it does describe value that we don't necessarily have represented in the literature.
Mm-hmm. So if I go and I look at the hierarchy of evidence, where would you place that case study? How does that fit into the evidence scheme or that spectrum?
Right, and that's a good question. So we all know about the food pyramid and where case studies and case reports and series rank, and especially in comparison with RCTs and such. And of course, when it comes to big picture things, you want to look at those big studies. But that's one of the reasons I highlighted Bill Boysenall's systematic review from 2012, where they did look at a lot of case reports and summarized them in the systematic review. Because some things you just can't study in RCTs, and that's why I like the cases about clinical reasoning, about sending out for additional medical testing or imaging, because there's no way you can look at that in an RCT, but it does show how much value we have as a profession in saying, hey, we actually have these skills, we can do this well, we know when to refer out. And that's exactly what Boysenall did in that systematic review. And I think that's where, if we keep adding more and more to the literature from that standpoint, the more we can make that argument for advancing our profession and for getting direct access and so on and so forth.
So now, tying into a comment you just made, when you look at the case reports that do get published, there does seem to be an emphasis on the reasoning that occurred in that case, as opposed to it just being a blanket, this is what happened. So if a newer practitioner or somebody who has not written up a case before were to try to do that, how would you recommend that they get their thoughts or their reasoning on the paper for that submission, as opposed to just here are the facts?
Right. Well, the first step would be using something like the care guidelines potentially, and those are easily accessible online. There's a specific layout as to what exactly you want to include in the write-up, which will then also help to kind of delineate where you want to go with both the case and then how you're going to present it. The other component of that would be just sound clinical reasoning strategies, making sure you actually kind of uncover all the different layers of the case in the clinic. And the first step to that would be obviously is doing a good exam in the clinic. Without that, writing up a case is going to be tough, if not impossible. So it's a very loaded question because there are so many different answers to it and so many details to consider, but those would probably be the easiest short answers.
And we'll get into your fellowship and some of the reasons why you chose to do a fellowship, which I think may speak to this question in specific, but we're going to get into that more towards the end because it's a common finishing question. The other thing that you did during the talk towards the end, where you were kind of breaking down the elements and gave some recommendations as to the intro, as to what the discussion looks like, things along those lines. For somebody who may not have written a case before, do you mind kind of trying to help them fit that SOAP note into the intro, the objective, the assessment? Like how do you merge those two together and what goes where?
Right. It's also a very good question. I mean, the first part talking about the introduction or the background and purpose in the abstract would be more just a broad overview of what you're looking at and why the case is important or why the topic is important in the first place. The next step would be, once you start to describe the patient, you're obviously looking at demographics and you're kind of describing why the patient is coming in to see you, and that'll be part of the subjective, of course, but again, more of the patient background. And then once you get into sections like the assessment, again, that you pull some of the information from the subjective that are more descriptors. So things that actually help you with guiding your differential or your hypothesis building, and then the objective would fit into that as well, right? Because that's how you determine whether or not this is something that you want to treat, or it's just a run-of-the-mill kind of case, or if it's something that you're going to refer out or going to add any kind of other element that's special that makes this a case study versus just a patient you see every day.
So when I think about a newer practitioner's notes, and I think about all of the sheer volume of within normal limits, measuring a range of motion that's supposed to be 180 degrees, and they write down 178 degrees. Do you have any recommendations you might give somebody when it comes to pulling out that objective information or subjective information that's important, especially since a lot of journals do have caps on how many words you can have?
Right. And I think that goes back to talking about being able to do a good exam in the first place. And I think that's where, I guess we'll talk about that later, but I think that's where residency and fellowship is also very important because it does help with those skills for sure. But I think the biggest question is what's valuable not just to the clinician but to the patient as well, or what's important to them. Because a patient is not going to care whether their range of motion is 178 or 180. I don't think they care at all about that. What they do care about is the functional stuff, is whether they're able to play with their grandchildren, whether they're able to bend over and tie their shoes and those kinds of things. And I think having the objective measures reflect what's important to the patient is not only better for your own outcomes and for tracking your progress, but also it's going to give you a lot more information on whether the patient is actually improving or not. Because you can get a few more degrees in any kind of range of motion and the patient's going to feel exactly the same. That doesn't help anybody really. So if you're thinking about writing up a case, even from the get-go, or even just for clinical practice, making sure that your objective reflects what the patient is there for. And I think, a little bit of an aside, but that's where I think the patient-specific functional skill is also very helpful. And what I like to do with that is All my goals I do with the patient. I don't like writing goals like achieve X range of motion or get 4 out of or 5 out of 5 on MMTs, because I don't think those are good goals. But just having goals that are meaningful to the patient, might as well do a patient-specific functional scale with that right away, and then you got your outcome already, and the patient are going to be able to track that progress as well.
So one of the concerns that when I was earlier in my career and I was trying to publish a case, which did get rejected, but that's a whole nother story.
Right.
One of the concerns that I had was if I had 1 or 2 missing time points where I didn't collect that objective measure or that outcome measure. Do you think we need to be very stringent since it's not a research program or a research project? Or do you think there's a little bit of flexibility provided you have it at those key time points, such as entry into care, maybe halfway, and then at discharge?
That's a very good question, and that might be even a better question for an editor of a journal, because they can probably tell you how important that is for acceptance or rejection. But again, I think it should be more meaningful to the patient, and it's hard to determine what the midpoint is if you don't exactly know how long the patient's going to be there. So I don't think it's something you need to ask every single visit to get that rating necessarily, but I think having a conversation about meaningful things to the patient every visit during your subjective, even if you don't get the number, is going to be helpful, because that's going to make it easier then to potentially go back and say, hey, where were you at that point? Where were you, later on? And I do recognize it's tricky, right? Because you're not going to give them an outcome measure every single time. But that's, I think, where the patient-specific functional scale is definitely helpful, just because the patients actually care about it. Mm-hmm. They notice it every day.
Yeah.
So I don't know if I've fully answered your question, but
I think you did. I think you made it a little bit. You made it a little bit more of a well-rounded response. I think using that patient-specific outcome measure or any outcome measure that speaks to that patient and what they want to do does seem, at least in my clinical practice, to kind of pull them back into like, hey, I do this every time, or this is what I'm still having problems with, which can help trigger the clinician to, oh yeah, I need to give you this again,
right.
As opposed to that random outcome measure that may have 2 questions that really speak to that patient that they're not going to talk to you enough to kind of trigger, oh wait, I got to give them the blank outcome measure, because
right.
That's not what's their reason for being there. So
right, and the way I was taught in residency as well is, they use the terminology of subjective and objective asterisks, whatever you want to call it really, but instead of just asking the patient, hey, how are you doing today, and them just saying good because they're being polite and conversational, asking specific things like, how are you doing with bending over and tying your shoes, or whatever is important to them. And if that is part of your goal section and you have a patient-specific functional scale, and that asking that every single time they come in is going to make them think about these things too. And if these are hallmark signs of what limits them, then you're going to get a much better idea with that. So whether or not you get a specific number, it might be important for submission criteria or for acceptance, but I think just clinically, even just having those subjective asterisks and constantly asking about that, I think is really what makes the difference.
So would you recommend that our listeners who are interested in putting a case out, maybe not necessarily right now, but in the future, would you recommend that prior to them seeing a patient, maybe just getting a little bit familiar with our key journals, JMMT being the larger one, familiar with what they require for submissions?
Oh, certainly. Before you even submit anything, you have to take a look at what the requirements are, because most journals have slightly different requirements. Most of them are very much based on care guidelines. But you just go to the journal website, take a look at it. A lot of times they'll have really helpful hints as well, or tips as to how to approach the whole project. And then read as many case reports as you can, especially the ones that are similar to your topic, because at the end of the day, those are the ones that were successful, and you already know what the journal is looking for and what they like. I think that's definitely the best starting point for sure.
So thank you for that answer. the next question kind of comes from the after side. So we talked about the pre side, now the post side of submitting. Any words of wisdom for that first rejection or that first response for edits that our listeners might be able to take and take that blow a little bit easier?
Yeah, I mean that's always tough, of course, any kind of rejection, but I wouldn't take it personally. I don't think there's a single researcher who hasn't gotten rejected, and there's a good chance that most people get rejected a lot more than they get accepted. But at the end of the day, I think it's just an opportunity for feedback and for improvement, right? If you get flat out rejected, I would still contact the journal and ask, hey, is there anything I could have done differently or could have done better? Just again, so you have that learning opportunity. Or if they send it back to you and tell you to do certain edits, then obviously go through that and figure out ways you can be better or where they're coming from. And I'm sure some of the things are nitpicky, but most of it is probably just going to be very valuable information, and it's going to make your case report better than what it was.
And may help them out with a future case report if what they submitted, there's just not a way of redeeming, per se, to get into that journal. Learn basically from what they gave you for feedback. That way you know I should collect this, or I should make sure I get this information for the next one. Is that also...
Yeah, exactly. And so one of the research projects I'd done in the past was when I was a student. It was one of those capstone program or projects, and it was a case report as well. And the collection of data was very inconsistent, just because the patient didn't show up that day, or the clinician forgot to collect it or whatever. So it's kind of going back to what you were asking earlier. It didn't look very clean in terms of graphing. And that was one of those things, again, where knowing that now, I probably would try to be a little more consistent if I know it's probably going to be a case. So just learning from your mistakes, obviously, is the big one. I think another thing that's been really helpful is trying to present it as a poster first. So especially here at AAOMPT, you're going to get so much good feedback, especially people here are just willing to teach and willing to help you out with whatever. And I've had a handful of posters already at AAOMPT and a little bit at CSM, but the feedback I've gotten at AAOMPT so far has always taught me more than I've actually learned putting the poster together. And starting with that can be really helpful to even just get you going on writing up a case report.
All right. So all very valid and very valuable bits of information. So Alex, you currently are in a fellowship.
Correct.
And one of the questions that we ask a lot of our guests who are fellows is what they would say to someone considering fellowship. But I'll just rework it for you. What was the main driver for you that was like, I need to do a fellowship?
That's a good question. So when I was a student, I first got exposed to fellows, and just seeing the difference in clinical skills between non-fellows and fellows, and even people who have their OCS, and comparing them to fellows, there was just a huge difference. And I'm one of those people, I'm never satisfied, and I always like to get better and learn more. And to me, since then, it's just been the epitome of clinical practice. And the residency I did, AAOMPT, was almost exclusively fellowship-trained clinicians. And I mean, even just doing the interview when I came to the clinic, to just spend time with them and shadow them. I was watching them do evaluations, and I'd never seen anything like that, even in my clinical rotations. And I knew that's where I want to be one day. And I knew residency was going to be the first step for me. And this is just for me personally. People get there different ways, right? But for me personally, I knew residency was the way. I did that residency with AAOMPT and learned a ton. But I knew I just wanted to get even more. And to me, AAOMPT is really the height of clinical excellence, combined in an organization and a conference. And I think being part of that is really what the goal is originally.
Excellent answer. So here is my more, I'll call it a little bit of a soapbox, but also I think there is some merit to my question here. One of the things that we see with a lot of the cases that have been published, that the person ends up having a non-physical therapy diagnosis, or I don't want to use MSK because PT does treat a lot more than just MSK, But those ones, they tend to use the differential diagnosis label.
Right.
And if we go back to the definition of a diagnosis, it's a label that should guide treatment to a better outcome. The medical diagnosis is not a PT diagnosis. So I always have a little bit of conflict in my mind when they say, this is differential diagnosis, and then the authors will put a few different possible medical diagnoses that they were thinking, and ultimately it ends up being something completely different.
Right.
Should we be using that term differential diagnosis, or should we be using something a little bit more extensive, such as screening for referral?
Right. I think that's a very good question. I think that opens up a lot of potential avenues, especially when it comes to scope of practice. So I'm not even sure where to start to unpack that one. But I think at the end of the day, I think it's okay to use it, especially in an educational setting and a conversational setting, because it's a term that we all know what it means. If you talk to your physician colleagues, they know what you're talking about. I think one of the big problems we have as a profession is that we like to come up with things that different parts or different factions understand, but other professionals don't understand, or different PTs don't understand what we're talking about. So I think using language that is a little more uniform can be helpful, especially in talking with physicians, but then being well aware of the limitations thereof, and obviously being aware of what our scope of practice is. And it's kind of a fine line, I think, that some people have to be aware of. But I feel comfortable using the term differential diagnosis. I definitely see where you're coming from, but I think we have to be aware of what the scope of practice is. But one of the conversations I had with different physicians, and it's not exactly the same topic, but similar, is PT assessments. And talking to surgeons, a lot of times they have no idea what the assessment says because it's stuff they never heard, or they don't know what it means. And what they actually, the handful that I've talked to, what they have told me is they would actually prefer if we did use medical diagnoses, because then they know what the patient looks like. And my caveat for that would just be using language like signs and symptoms consistent with whatever medical diagnosis, because then we can communicate a lot better. And I think it kind of goes along the same lines with the differential diagnosis question. I would say it is okay to use as long as we make sure we stay in our lane and don't cross that line too much.
Yeah, and I do tend to use in my clinical practice most consistent with blank.
Right.
And I always do come to that conundrum of knowing that a lot of those types of diagnoses, the relationship between the pathology and the pain is not the best
Correct.
There is. But
Right.
But it does. I agree with you. It does help out for using a shared language that we can all house ourselves around. So I guess I like where you're coming with for your answer. I guess the only other thing that I would also ask would be, if we're trying to use differential diagnosis, do you think it's wise for that person looking to write up their case who came up with 2 to 3 potential diagnoses that may have not even been in the right system of the body? Should they be publishing what they were thinking that led to that referral that ended up ultimately being not the right system? Not necessarily because it's bad that they were thinking that, but more from a, JMMT's on Medline, JOSPT is available. Might it be bad for other professions to see some of our reasoning going to the wrong system? Especially if we're trying to get them to look at direct access and
Right.
agree with that.
Yeah, again, it's a very loaded question. I think as long as you can justify it, I think it's probably okay. I think the case I used for my presentation earlier was a good example of that, because even going around as we did our breakout sessions with the groups and had people talk about what they thought it might be, the consistent theme was people were thinking that it was either cancer, some kind of neoplasm, or AAA.
Mm-hmm.
And that's exactly what I was thinking in the clinic, and that's where the alarm bells went off a little bit, and eventually what led me to refer the patient. And it was kind of misleading in a way because that's exactly what it looked like, and ended up, spoiler alert, but it ended up being just a big bladder stone. And so I think it's fair to make those, or to list those differential diagnoses, as long as you have good reasons for it. If it's something where you don't have a good reason for it, I'm assuming you probably wouldn't get published in the first place.
Excellent point.
Right. But I think for other professionals, it might be helpful for them to see as well, if they can follow it and if they see the same presentation and say, you know what, I think this could actually be a AAA, but then they see that we have that same thought process, even if we're completely wrong, like I was with that bladder stone. I think at least they see that we can recognize certain patterns and make the right referral, instead of just,
3 times per week for 4 weeks.
Exactly, right? Yeah. Which, I mean, potentially could be more harmful than anything else, right? Mm-hmm. And actually just last week I had a case where, things just didn't quite add up. I wasn't able to really separate symptoms, and the referral was for BPPV. But even looking at the neurologist's note, which luckily I'm in a health system where I have access to all the notes, it didn't seem like he had really findings that he was confident in. So I messaged the neurologist. He called me back the next day and we talked about it. And he said, I'm really happy that you found the same thing, because I wasn't sure about this. I was already thinking I should probably do some imaging with this gentleman. And ultimately he was more excited about the fact that we agreed on it rather than me sending somebody back that I wasn't sure about. So I think in some situations can be a problem with different physicians, but at the end of the day, I think as long as we can justify what we're doing and what we're thinking, I think it's probably more beneficial than harmful.
Great insight both into your presentation, into the ways that you have provided recommendations and those recommendations themselves for individuals looking to publish cases, and maybe even how those cases can eventually influence the bigger research bodies. And of course, also getting your insight into the differential diagnosis terminology. So with that, Alex, just in case we have listeners who do have some follow-up questions for you, do you mind actually giving us whatever method of contact you prefer?
Yeah, that's no problem at all. So right now I'm at Duke, so it's probably the easiest. So it's alex.bengtsson at duke.edu, and then Twitter might also work, but it's at AAOMPT, so it might be another good way to get in touch, because I do try to get off my work email as soon as I'm done with work.
I understand it. Shut it down as soon as you can.
Exactly, yeah. But those would probably be the easiest too.
Fantastic. Well, Alex, have a wonderful rest of the conference, and we look forward to the future work that you're going to put out for both the profession but also for the association.
I appreciate it, and thank you very much for having me. It was a privilege.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.